Hello, everyone. This is Dr. Mary Lauder, and you are listening to the Since You Put It That Way podcast. It's the show that examines various health, wellness, and medical topics from unique perspectives. We will be having discussions and guests that will cause you to pause and consider, well, since you put it that way. Hi, welcome to today's episode of Since You Put It That Way. I'm going to be in conversation today with Dr. Scott Russo. He is an orthopedic specialist in West Michigan. He specializes in the surgical and non-surgical treatment of spinal disorders and orthopedic fracture care. Dr. Russo is accomplished in all areas of cervical, thoracic, and lumbar spinal surgeries, including trauma, tumors, degenerative conditions, scoliosis, and herniated discs. His subspecialty of interest is in the non-surgical and surgical care of pediatric and adult scoliosis and kyphosis. Dr. Russo is also part of the clinical faculty at Grand Valley State University, Michigan State College of Human Medicine, and the coordinator for the spine section in the Grand Rapids Orthopaedic Residency program. Today's topic is going to be on the prehabilitation process, meaning getting a patient ready for surgery. And in addition to the podcast, it would be good to download the transcript from today, as well as an FAQ page that I've put together. It's actually a few pages that goes over some good ideas and information that you as a patient can use for yourself or your loved ones as you prepare for your surgeries, or even if there's a life-changing diagnosis that occurs. So without any further ado, here's our conversation. Since there's two of us physicians, I guess that's a paradox. So enjoy today's show. So Dr. Russo, go ahead and explain to us, go ahead and introduce yourself to us. What should we know about you? What's important?
Well, Mary, thank you so much for the opportunity to share my story and my interest and passion with your listeners. Yeah. And so I'm just a young man from east side of the state, grew up in St. Clair Shores, right outside Detroit, went away to Michigan State for undergraduate. And from there, after getting a degree in chemistry, I went to Wayne State University School of Medicine. Yeah. I was blessed to have graduated from Wayne State and obtain a residency in orthopedic surgery in Grand Rapids at the Grand Rapids Orthopaedic Residency program. Yeah. So long ago. And from there, I went and did a fellowship in spine surgery, and then came back to Grand Rapids. So came back to Grand Rapids and joined two fine orthopedic surgeons, and was there for a couple of years before I went out to form the Spine Center West Michigan, which Spine Center West Michigan was a multidisciplinary program that had both medical component and rehabilitation component. And that kind of started my relationship with physical therapy, rehab, and health and wellness. That was kind of the introduction. From there, we went and formed orthopedic and spine specialists, and then ultimately ended up at Orthopaedic Associates of Michigan now. And I've been there for 17 years. Okay. And, I am a member of the American Academy of Orthopedic Surgeons, North American Spine Society, Scoliosis Research Society, which is one of the preeminent research societies in all of spine surgery. I also am part of Michigan Orthopedic Society. I am a resident educator, former coordinator for the spine program for the Orthopedic Residency Department. I'm also an associate professor of surgery for both the Michigan State University School of Osteopathic Medicine and School of Human Medicine. And I sit on the alumni board for the Wayne State University School of Medicine. So a lot of different things. I'm very committed to teaching and education, but more importantly, I'm committed to my patients and patient care. And so this conversation we're going to have today is, based on a lecture that I just gave to the Michigan Osteopathic Association this past weekend. As you know, you were an attendee of that, preparing your patient for surgery and beyond. So that's where I am right now today.
Yes. Well, welcome. And we're so glad you're here. We shared patients many years ago when I practiced in Michigan right out of residency, and it's been really good to reconnect. And so I'm really appreciating that. After we've both been, working, I think I've been a physician 30 years. So just, right on your heels there. So a lot of good experience. There's a story you have, though, about kind of what really kind of put you in this direction, where you had an opportunity to experience maybe a healing crisis, an opportunity for enlightenment, for growth. Can you share that before we get into some of the details of prehabilitation?
I would welcome that. Yeah. So in 2008, my life was ambushed overnight, and I wasn't ready for that. And so I went from fully functioning high energy surgeon to patient. And I was admitted to the hospital with high fevers, in sepsis, with a staph infection in my blood and an abscess in my spine and a heart valve that had vegetations on it from the bacteria.
Mm-hmm.
And I was pretty sick and really, really scared.
Mm-hmm.
And after 8 days and almost dying, I was able to leave the hospital.
Yeah.
And I left the hospital and I had three things: a PICC line in my arm, which is a long-term IV. I had a bag of antibiotics and a couple of follow-up visits with the infectious disease and cardiologists, those specialists. But nobody told me how to recover from such a debilitating illness, 20 pounds of weight loss. So I went home and I didn't realize it till I reflected on it, that I was depressed. I didn't know what to do. And I somehow just figured it out. I started to walk to the end of the driveway and back, and I just progressed up the street until I could build my strength up. I started eating healthy, and but I think the mental piece was what really left me here, as I was going from 60 to 0 overnight.
Yeah.
And how would I provide for my family now?
Right. So high functioning, near death experience, tremendous amount of infection and recovery for the body to recover. But I think the mental and emotional part is really a key, because I think one of the things in medicine that we perhaps don't do well enough is how to prepare patients for what they actually may experience.
It's a true statement. It is a true statement. The mind either works for you or works against you.
Right.
And while it's the patient's choice to embrace it, it's the healthcare system's responsibility to encourage it.
Yes.
And that's where the healthcare system really has taken a backseat.
Yeah. And you said you were scared.
Oh, frightened that I was going to have my chest sawed open and my heart valve removed. And I can't tell you anything that's more frightening than that.
Yeah. And the inside scoop, meaning what goes on in a hospital, what goes on in the surgical suite, what goes on the medical floor in the ICU. I mean, you're intimately acquainted with all that, and yet you were scared.
That is correct.
So I think we can't leave that statement untouched, because if you're scared and you know what to expect, think of our patients and what they don't know what to expect.
That's a true statement.
Yeah.
And I had to go a little deeper. I had to figure it out.
Yeah. Yeah. And I think that this is really something that, my side of this table here in our discussion is primary care, getting all the patients ready for surgery and meeting all the criteria. But by and large, the patients have always come back to me and said, hey, the specialist said this, that, and the other. I don't know who to believe, what to trust, because I trust you. I've had that relationship. So really, one of the things we're talking about here is how developed is that doctor-patient relationship within a systematic approach to patient care?
That is true. I mean, the relationship between the primary care physician and their patient is sacred.
Yes.
The surgeon kind of comes into that as a side piece.
Yeah.
And that's where the system is not communicating.
Yeah.
The surgeon says to the primary care doctor, hey, clear my patient for surgery. And the primary care does that. But they're not really talking about what are the real needs of the patient.
Right.
And how do we get that patient ready to do battle in the operating room?
Right.
And then to recover afterwards.
Yeah. I had a well-known acquaintance recently who had a significant medical procedure, And the outcome was going to change a considerable amount of physiology within their body. And it was in the cardiovascular system. And the patient just had no awareness of it. And I just sat there and I went through, I don't know if you'd call it the mental gymnastics or, I'm Joe's heart or whatever, but I just went through all the things like the heart would be experiencing and feeling and what the blood vessels would be doing just in response to how the volume changed because, cardiology is, fluid dynamics. And so just the basics of those mechanics changing of how that could only imagine how that could feel inside of a person's chest. So same thing, getting a valve replacement, cracking of the chest, moving of the bones, being wired back together. I mean, that's just a tremendous amount of surgery, and yet we do it all the time.
All the time.
Yeah.
We do it all the time. The patients don't have it all the time.
No.
But we do it all the time.
Yes.
And it's their first time, and they're hoping it's their only time.
Yes.
And the question is, how do we prepare them for that experience?
Right.
So that more of this concept of anti-fragility, right? I work on resilience, mental resilience, physical resilience, nutritional resilience. But how do we take patients and have them come out of an operation stronger for it? And that's something that's never been talked about in healthcare. That's
correct. That's correct. And you used a term, interestingly, that I've always considered, but I've never heard a surgeon say it, that a surgery is traumatic. Oh, and I was like, yes, it is. And I honestly believe you're the first physician and first surgeon I've ever heard use those terms.
Well, I appreciate that because I truly believe it and I understand it and I feel it for my patients.
Yeah.
I know what they're going to have.
Yeah.
And I want to respect that. And that's why I give them the tools to deal with it. And then the choice is up to them if they take the tools and use them.
Yeah. So your experience provided you not only compassion, but, really empathy. You could definitely identify. And knowing you before, many years ago, I never considered you not empathetic, to be, interestingly. And so it's interesting now to hear how much more that has actually permeated your practice and how much influence that has in the decisions you make and the direction you're taking, not only your patients, but, how you want to influence the medical system.
That's a true statement. I think there's such opportunity for change, such power in the relationships that physicians have with their patients, surgeons have with their patients, and surgeons and primary care physicians have with each other, that we're not tapping into this. Yeah. I understand medicine is a business, but the reality is this is the opportunity to improve the lives of our patients and their family members and everybody else that we touch.
Yes. So medicine's changed, though, because, and I would put it on the backs of the electronic health record, and I would put it on the backs of large systems that are, very numbers oriented, very driven by procedures, very driven by referrals and what we would call downstream revenue. But I think the electronic health record is a big disruptor that we have a lot of, I would call it negative consequences from, or unfortunate consequences, because we don't have the ability to bump into one another as physicians anymore, pick up the phone and call. I can't even, it's really hard for me as a physician, as a primary care physician, to get the specialist on the phone. And we used to do consults all the time, sharing patients. We would get a letter back. We would send a letter. We'd have a specific question that we asked in a consultation. We'd look for that answer in return and then the next steps. And the communication, I felt, when I first was in practice in the 90s, was pretty good.
Oh, yeah, it was a blessing. You'd walk down the hallway and you'd see your family physician was making rounds. Yeah. And nowadays they're hospital-based physicians, and they're good people. They're great people, and I'm very thankful for them.
Yeah.
But it's not like it used to be where we would connect regularly.
Yes.
And we'd see each other in medical records, and now everything's electronic. So there is truth. to the fact that that has disrupted
Yeah.
the relationships that we have and the ability. But I always still welcome any primary care physician who has a question, has a concern, to reach out to me personally.
Yeah.
Much rather talk to them. Mm-hmm.
Yeah. I think the other thing that's been a bit of a challenge too is I think we probably discharge people home who are more ill now than what we used to admit them to the ICU.
I think that's true. Yeah, we're doing a lot more surgery outpatient on older and more mature patients, and so those are changes in the times.
Yeah, and that has been, I think, difficult to catch up with, and I think that's I wonder if that's played into the idea of how prepared patients are, of the communication with the patients, the the consistency, between the specialist and the primary care doc.
Right. And I think that's the real opportunity for what I am proposing or trying to do, is that prehab specialist, so to speak, who really kind of looks at the patient from a preparatory standpoint and communicates with the primary care physician. These are my concerns regarding the risk factors. Can you help address them? Can you optimize them from the medical standpoint? To the surgeon, is we need more communication with your patient. They're coming in with all these questions. I can help you if you'd like, or let's get them back in the hands of your staff members and let's get those questions answered. Let's build the social team around them, right? The family. Do we engage at church or other things? So how are we doing this? So the patients come in seamlessly, they flow into the system, they get their care surgically, and they go home and they recover quickly with less likely complications and maybe, hopefully, ideally, lower cost, better for our healthcare system.
Right. So what is, if we were to define prehabilitation, because it's kind of a new, I would say it's an old new concept or a new old concept, or, how would you define that?
Yeah. So I think the way to look at prehabilitation is that it's pre-surgical optimization, right? It's the process of taking one before surgery, identifying where they're at that point in their life functionally. In this case, globally, what are their medical risks? What's their nutritional status? What's their mental well-being? What's their physical status? And taking and elevating that through a series of processes to a new level. So when we wound them, when we injure them with surgery, they recover quicker.
Yeah.
Right? Because if you start at a frail state and then we injure them, they may never get back to their baseline. And what a detriment that is.
Yeah.
But if we build them up and we give them new tools, a health and wellness toolkit, so to speak, then we injure them with surgery, because there's an appropriate injury that goes along with surgery. They recover quicker, faster, more successful, to be a happier patient, lower cost, better value for care. Yeah.
And I think, speaking to maybe the emotional and mental health part, maybe the fear would be diminished, because that communication's there. They would feel, I think two things come to mind: seen and heard.
Yeah.
And oftentimes, the advice for patients can be, you got this, you can do this. Yep, it's a difficult process, but you got this. I mean, the body has the inherent capacity to heal.
No question about it. No question.
Get the parts together so it can do that, and then get these, get the emotional component. I think so. If you talked about nutrition, so what do you see let's look at orthopedics and spine, because those are, often chronic conditions that bring a patient in, osteoarthritis. How do you see nutrition being able to impact that patient if they were getting ready for a surgery in this process?
Well, let me tell you just kind of a funny way of which I approach nutrition with and health and wellness with my patients.
Yeah.
So I ask my patients if they've ever had a new car before. And most patient has. And I say, well, what's the cost of a new car? Let's just say $50,000. I said, it's pretty expensive, isn't it? They go, oh yeah, that's a lot of money. I said, when you get a new car, do you put the worst gas in the car? Oh no, I'm not going to go to the worst gas. I'm going to make sure that I give it the best fuel. Right. And I said, when your car needs a tune-up, it's at 3,000 miles. Do you take it in for its tune-up? rotate the tires? Oh, absolutely. It's a lot of money, $50,000. I say, well, what's the value of your body over the course of your lifetime? And they say, oh, I don't know. I say, let's say millions of dollars that you will earn for somebody else or for yourself, all the joy you will give to other people and to yourself. But why do we as a society treat our bodies like a second-class citizen? And so the reality is that the food we put in our body is the fuel for our body. The exercise, the mental well-being is the tune-up for our body. We don't do that regularly. We don't celebrate ourselves. And we don't do this because we're not assuming responsibility as individuals for ourselves. And we have free will. That's the problem, or the goodness and the greatness of our life is we have free will to do what hopefully drives us. But at the same time, we miss out on how to care for our bodies. So nutrition is the fuel. That is the most important thing. And that fuels every cell in our body throughout our lifetime.
So in the prehabilitation process, are you having folks meet with a nutritionist, or are you have staff members that share information, or do you have handouts? How are you practically approaching that?
So we have a dietitian on staff, and we make that patient, we don't make it, but that's part of the program. So as one arm of the program, 3 parallel arms, one other arm of the program, the patient meets with the dietitian. The dietitian does a nutritional assessment, right? Screens them, assesses them, and puts in place. Ideally, we use the Mediterranean diet. It's probably the most well-known studied diet out there, and pretty darn healthy. And we probably lead it a little bit more towards the ketogenic bent, so keeping down the sugars, certainly no processed sugars, and we put that in place. And so that's the anti-inflammatory piece of the body. So the patients are working with that.
Yeah.
If the patients are overweight or obese and they want to lose weight, or they need to lose weight before their knee replacement or their spine surgery, then we have a meal system that's a VLCD, very low calorie meal system, ketogenic in origin, high protein, that jumpstarts that process. So we get them the win for a couple of weeks in a row, where they get 5 to 10 pounds a week weight loss on a very low calorie. They work with the primary care physicians if they're on diabetic medications to adjust them appropriately. We engage them also in the physical conditioning piece. So now we're getting to right size their body. We're getting to condition their body physically, and we'll talk about that more now. A whole time they're doing their mental well-being, mindfulness exercises, positivity drills, and their different rituals that kind of optimize their mind for the process. So that's what we do. That's the nutrition piece.
Yeah. So what can you share with us a success story that you've had with that with a patient that you can think of?
Success story with the whole process? Absolutely.
Yeah.
Gentleman came in, he was having his hip replaced. Not super heavy, but probably BMI between 30 and 35. We got him going on the Mediterranean diet, a short week of the meal system, lost 10 pounds. He was working with me on his mindfulness. We helped him, most importantly, identify his why for he's having surgery, so that he can play the sports, play golf comfortably. That was his why for having his hip replaced. So now we got him going on the Mediterranean diet. We optimized his weight, at least initially, gave him the tools to continue that on with fresh, healthy food afterwards. He was working with the physical therapist, strengthening his aerobic capacity. So we've got the nutrition piece, the physical conditioning piece, and then the behavioral wellness piece, all rolled into one.
What was his age, if I might ask?
He was 72, if I recollect accurately. 72. A big,
active.
Strong, powerful. What's that?
Was he pretty active before he needed his hip? I mean,
very active.
Yeah. So you mentioned with him the why. And you had mentioned that in the lecture, understanding the why of the patient.
Yeah, so when a patient understands their why, when I understand their why, I can guide them. When they understand their why, they can guide themselves. And it's about personal leadership. I mean, it really is. And personal responsibility. So when a patient knows their why, everything else follows. If they know that to get a spine fusion, they're going to have to get off tobacco, and they know that they want to have a spine fusion so they can go out and play golf or pickleball or one of those things, or walk their daughter down the aisle. When they know that, then quitting tobacco becomes easy, because they know the outcome will be a much higher likelihood of having a great success.
Yeah.
They'll eat healthy, they'll lose their weight. So that's the why is what drives all behavior, the purpose.
It's interesting because we see, I see patients in a chronic fashion, years, you might have them in your primary care, and getting them to understand personal responsibility, getting them to understand that they have choices versus, well, this is just what the doctor told me to do. I think, and I feel that that's kind of a generational thing where the older generation, the front end of the baby boomers, who we kind of go there, tend to be a little more paternalistic in their approach to medicine, sometimes just do what the physicians say. And the younger boomers, Gen Z, Xers, those millennials, they like questioning a lot of things. And so the personal responsibility then fits in there. But have you run into that where maybe patients didn't really want to pick up that sense of personal responsibility?
All the time.
Yeah.
Fortunately, it's endemic in our society that patients want to either say, I'll try it. And, I will say, if you say you're going to try something, it gives you an out, right?
Yeah.
Historically, when nations conquer other nations, they burn the boats because there's no going back, right? When they land on a shore.
Yeah.
Our patients don't want to burn the boats. They always want to say, I tried, see, I couldn't do it, but I tried.
Right.
I'd say it's not acceptable.
Right.
Acceptable is, I'll tell you what's best medically based on the literature for you.
Yes.
But it's up to you to embrace it and for us to have a conversation and me to support you as you go on this journey.
Yeah. Yes, I think that that's really important because, ethically, that's correct. You're making medical decisions. You're providing your guidance as a professional, as a physician, as a specialist, and then the patients can choose. That's their autonomy, but that's also their informed consent, and that is their, right to do that.
That is true. But I also choose to take care of them in the operating room when they're asleep. And they could have a catastrophic event. And if they're not prepared, they could have a heart attack on the table. They could die on the table. Every time I operate on somebody, I assume the responsibility for their life. And I don't take that responsibility lightly.
Yes.
Because there's a family member waiting out there. And so it's important for patients to assume as much responsibility for their life as I do as a surgeon.
Yes. I think that's actually an excellent point. I think sometimes patients think, and we sometimes as physicians think things are so routine, but each time that, a patient goes under anesthetic, truly, their life is in your hands.
That is correct.
Yes. That was never lost on me when I did my surgical training. I'll tell you what, I was always kind of up there. I had conversations with patients often before I, assisted and just touched base with them when they were under anesthetic. And for me, participating that way as a physician was very meaningful because I knew, as it is in the operating room, you've got that screen where their head is up by the anesthesia end. And then below that, where everything is draped and sterile and doesn't look like a patient, it looks like a procedure down there.
And it's true. And that's where you have to be. Your head has to be on the procedure.
Exactly.
Right? You're not worried about that because the anesthesiologist is fortunately taking care of that.
Yeah.
Things are routine until they're not routine anymore.
Exactly.
And then it's a problem. So our goal with prehabilitation is to make sure that things will stay routine in the operating room. And that their recovery will be routine in the operating room. But even more important, Mary, is the concept of the potential changes that giving these patients all these skills in advance, should they embrace them?
Yes.
Will they carry them on after the surgery to live their best life?
Yes.
And so you learn your why up front, you get these tools, and then downstream, the healthcare system benefits greatly by the patients changing behaviors so that they're fueling their car the best thing, their body, exercising regularly, and having a positive mental attitude, really celebrating their life and their newfound successes from surgery.
Yeah, I think that's an excellent point, because a lot of patients have a perception that they want to get back to what they were doing, but actually what you're promoting is going beyond where they were.
Going beyond.
Yep. And optimizing. So using that surgical intervention as a chance to optimize their health and their life and impact that, in many levels.
In ways that they cannot even imagine.
Yeah.
And I understand that the family physician, the surgeons don't have the time to do that. But if a program like ours is able to introduce that mindset, and it's reinforced by the dietitian, by the physical therapist, and the prehab physician, that supports everything that the primary care doctor has been trying to do for a lifetime with the patient.
Mm-hmm.
What the surgeon's trying to do in this short window of time with the patient.
Yeah. What have you seen, and what has been your experience with reimbursement for a program such like this?
So we're early in our development, and so we're communicating with the insurance companies. I'm not entirely certain how this will play out with various insurance companies. So that is yet to be determined. I think there's going to be great value in it, appropriate from long-term savings. I think the literature shows that.
Yeah.
And it is my hope that the insurance companies will see the value of this, embrace it, and allow us to move forward and start changing the lives of the patients that they insure.
Yeah. Yeah. It's an interesting time, and it's a different topic, but one of the things that is really important in the area I'm going to go to in future podcasts has to do with who's controlling the purse strings, who's getting paid, who's actually paying for healthcare. And, we have a lot of people functionally uninsured in our nation who, could really benefit from things that are just typically not reimbursable. And just how that whole structure really needs to evolve, to be honest.
I think the idea of having skin in the game too. So you are investing a little bit of your own money in your own health.
Yeah.
And our goal is to, as we roll out our program, our goal is to figure out what's the most appropriately cost-effective manner to deliver this to the healthcare system, to patients in general in that respect. So it's yet to be seen, and maybe it's optimistic. But I'm an optimist, so I believe that there's ways to do this.
Yeah, I actually think that people who are positive disruptors, such as yourself and myself, we've got to act on what we really truly believe and how we, really, really want to care for patients. We have to.
Absolutely. Yeah. Got to forge ahead.
Okay. A couple more questions here I've got for you. This is a great conversation. So, in your mind, when you're looking at prehabilitation, what's the keys that makes the patient at higher risk for surgery?
Well, certainly, when we look at risk factors, we're looking at do they have cardiovascular disease? Do they have pulmonary disease? Yeah. What's their level of physical conditioning? Yeah. And we're looking at their nutritional status. Are they living with obesity? And people that are overweight or obese, they know they are. So we're not here to criticize. Yeah. We're here to support, to be an accountability manager for them, to support them in that journey. Yeah. But we know that if we can get them down, micro goals, small steps, help them start to lose weight, get them on a plant-based, appropriate Mediterranean diet, and with some fish, poultry, maybe a little bit of red meat, depends on what they like, we can start to tailor that down. If they're diabetic and their hemoglobin A1C is out of control, then we want to optimize that. So that's where we communicate back with the primary care doctor and the patient, saying, look, you got to be accountable for this. We've got to stay really strict to your diet. If they're running high blood glucose, we got to work on that. If they're a tobacco user, absolutely got to get off of that. I mean, it messes up their pain receptors and everything, and it really hurts their lungs, their blood vessels. If they're using alcohol in a significant manner, anywhere from 3 to 5 drinks a day, we know that we need to get them cut down on that significantly because that's hurting their liver, their clotting studies, how they process their food, their lining of their stomach and their GI tract. So we know that we have to do that. So those are the factors. And if they're living with depression or anxiety, we're not here to treat depression. We're not here to treat anxiety. We're here to give tools to help them deal with those emotional states when they're going into surgery. But if it's interfering, then we engage the appropriate consultants in that area too, working with primary care. And their primary care doctors usually know their patients so well that they already have that engaged. So we're just giving them tools to handle. So mindfulness training, positivity training. We teach them how to visualize coming into the hospital so they see themselves coming into the hospital. They've already done it in their mind before they ever get there on the day of surgery, and they see a successful outcome.
Yes.
They're already planning for that.
Yes. I teach my patients that. I teach them to, whatever their belief system is, to tap into that. So whether it's angels or ancestors or spirit animals, whatever they, really where their beliefs come from and what supports them, and look at every aspect, all the way from who greets them at the hospital when they register, getting ready for the surgery, going into the surgical suite, the surgeon, the team, everything, all the way through recovery, and every step, really all the pieces falling into place.
Can you share how your patients have dealt with this and what benefits they found from this?
Yeah, the biggest thing that they share is at first that they've been seen and heard by someone, that they actually have a fear and apprehension about going.
How important is that?
Huge, huge. And because there's a lot of things we can't fix or adjust, but to know that someone's with you. And it's very vulnerable to open up your emotions and not have control over the outcome of what someone's going to do with them.
That's very concerning, isn't it, for patients?
Yes. And so then you're giving over your control to go into a hospital. You're giving over your control to lose your consciousness. You're giving over your control to lose control over your bodily functions, all the way down to breathing. It's an exquisitely vulnerable position to be in.
You're stripped naked, aren't you? In so many different ways. Yeah.
Yes, it's there. And one thing they give you that's warm, rarely.
Rarely.
And and anything from, also disinfecting yourself the night before, the day of surgery, all the things that you do now to go in to get ready for a surgery. So that by itself is overwhelming, but it can be dehumanizing if it's just done in a procedural way. Well, this is what you do. This is what you do. And so for patients for me to ask them how they feel about that. Where do they feel they have questions? Where do they feel they just feel uncertain? And so listening to them. And it could take 15, 20 minutes, but it changes their approach and their comfort because I can encourage them to also ask questions. And then they feel that because they've asked me questions, I say, well, you're asking me. I'm no different than the person who's going to be helping you, just a different role.
Yeah.
So feel just as comfortable. So that has changed a lot of outcomes, just helping to waylay the fears and the uncertainty, because where there's uncertainty and lack of control, anxiety just goes off the chart.
That is the truest statement anybody could say.
Yeah. Yeah. And then just really, really, letting them know that by and large, everything's going to go really well, because it typically does.
Yes, that is correct.
And then just really paying attention to what their feelings are. And I always encourage people, as long as they acknowledge and understand what their feelings are. Typically we can describe 3 feelings, happy, sad, and angry. But as we increase our language to understand and identify our feelings and emotions, that helps us connect with ourselves more and with each other. So you could be feeling anxious. You could be feeling unsettled. Those could be different words than scared or overwhelmed. So defining that and being a little more nuanced helps a patient understand by opening up their experience a little bit more.
I would agree totally. I think that having that conversation and maybe teaching patients how to have that conversation with their loved ones.
Yeah.
And loved ones with the patient, because there's a lot of anxiety that goes back and forth at home that I think as caregivers, we don't see as clinicians.
For sure.
Right?
For sure.
And patients are like this. And,
Yeah.
it's really important for them to learn how to talk too.
Yes. Yeah. And I think that that's just really important. I think the mindset and the resiliency, because coming into alignment with how the body heals. I mean, the body knows how to heal. We cut ourselves and we don't sit there and, well, I can't come out today because I got to sit around and watch my finger heal. No,
Yeah.
you just have to get the skin together, maybe get it clean, and we go about our day because the body inherently knows what to do, right?
That is true.
And so then I think at a bigger level, the same thing, whether it's healing from an orthopedic surgery, a fracture, a spine surgery, the fusion, the body picks up and we put it in a position to know what to do even after traumatizing it.
That is correct.
So I think the keys to the optimization of the nutrition, the mindset, and all of the teamwork is something that is reminding the patient that the body's got this. It can do it. And it also takes energy to heal. Someone said, well, I have to do all this resting. I don't, I'm going to be bored. I'm like, well, you're actually not really, you're resting, but you're actually healing.
Right.
It takes a fair bit of energy to heal.
It does. And that's the purpose of physical conditioning, though. So what we don't want to do is take somebody who's already frail, put them through a big operation, and then they start to heal. But what they do is they start breaking down their muscle to heal. Right. And so what we want to do is fill the nutritional stores up before surgery, build up the muscle stores so that they have all the necessary substrate, necessary ingredients, so to speak, to form a great healing experience after surgery.
Yes. So in your mind, what do you think is the ideal time frame for the prehabilitation process to take place?
I think the literature supports, ideally, probably 6 to 8 weeks before surgery.
Okay.
And so it's not just surgery, though. These are patients who, let's say a person comes in the hospital with a femur fracture, right? They weren't planning on having an injury, but they have a femur fracture. They go through surgery just like I had my illness.
Right.
And they're discharged at home. This process can work for those patients after discharge. They're not sick enough to go to a rehab facility.
Right.
But they're going to go home, but they don't have a way forward. They don't have anybody guiding them down the path. Yeah. We can be that group, that team to guide them down the path. We can support primary care, support the surgeon that did their surgery, but also, more importantly, give the support to the patients to nutritionally get better, physically get better, and mentally really thrive going forward. Really put some support to the situation for them.
Yeah.
Or if it's somebody who's just living with a chronic illness, right? They're living with obesity. This same process could be used with patients with a chronic illness. So there isn't one piece is not more important than the other. All three pieces, integrated patient-focused care is what it's about.
Yeah. So it's different than just a pill for every ill.
Oh, for sure. This is not about medications have their place.
Right.
They're just a tool in the toolbox. This is about identifying what the patient's needs are, what resources they have or don't have, how we can support primary care in helping their patient get back to their best life.
Yeah. And different than a supplement for every symptom.
Yeah. No.
Because you've got folks who, I don't want medications, but I'll take a supplement.
Right. There's a place for supplements, no question about it. But we always want to power the body with healthy fuel, fill in the gaps with the supplements, right? And then just use the other tools, get their mind in place, and then start training their body, getting them back into shape. And they may never have been in shape, right? They could have suffered an injury or illness or go into surgery and never really have been in shape in their life.
Yeah.
Like you said, they expect the physicians to do it, but the reality is they have to be the driver of the process.
Right. So there's a lot here in unpacking this where I could see this really comes in needing a lot of reworking and change with our healthcare system.
Yeah, no question about it. There are a lot of opportunities for our healthcare system here.
Yeah.
And I think this is probably the most sustainable aspect of it. And it's probably the most challenging and difficult aspect of it is going past free will and saying, okay, you do have free will, but I'm going to ask you to redirect your free will towards a different path towards life.
Yeah.
And this is lifestyle medicine applied to pre-surgical preparation.
Yeah.
And hopefully extending past the surgical experience. So leveraging the surgical experience to provide an excellent path towards future health.
Yeah. I see that too as the surgical experience being just another entree to be able to access the patient for change.
Correct.
And I think that that's really important because, it's not just, we've often left the prevention only to primary care. And it does wear a primary care physician out. I'll raise my hand as one in the room when patients, you're going around the same conversation time and time again. So it is good to see more of a team approach. It is good to see, surgery being an optimal opportunity for a lifestyle change. And
I think it is such a unique situation that it needs to be leveraged. It needs to be growing that whole mindset of that. And I think we're at a crossroads right now with expenses going up and illness going up and population going up, that we have to make a decision that as individuals, we're responsible to have control of our lives. And the healthcare system has to provide the tools to achieve that. That's how I look at it. Yes,
I think that's great. I agree fully. I think we could have hours more of conversation.
I would welcome that.
Yeah. So I think it may be good to come back with some patient stories, some things more that's been looked at as you go down this path furthermore. I'd like to revisit things down the road from now.
I would welcome that very much.
So today, I think really I appreciate Scott, your approach. I appreciate you as a physician, as a healer, as a community member. And not many surgeons pick up on this, and I appreciate that you're really leading this. And I'm really thankful as a primary care physician to connect this way, because it's been in my heart and in my drive as a primary care physician to care for the whole patient, and that's really what you're talking about.
I am. I think I've always celebrated my relationship with primary care practitioners in so many different ways.
Yeah.
Physicians, advanced practice providers do such a lion's share of the care in the hospital, outside the hospital. So, and I'm very grateful for the opportunity to share my story and to share what is becoming a very deep passion and hopefully a movement to change how healthcare is delivered. I know there are a lot of people out there that think along these lines, and I just want to try to be the catalyst for this process and catalyst for and speak for patients. Yeah. And in fact, hold patients accountable, right? For being responsible for their health, but helping them see what the future can hold that's so much different than their past and their present.
Yeah. Well, thank you for being a part of our podcast. The title of our podcast is Since You Put It That Way. So, since you've put it that way, we will continue the conversation down the road. And thank you again for being with us today.
Thank you for having me, Mary. I appreciate that so much.
Thank you for joining us on the Since You Put It That Way podcast. Today's episode was written and produced by Crowded Table Productions. Technical editing, Malin Long Lopes. Sound editing, Jonathan Fiegel. Music, The River Jordan, written and performed by May Erlewine. Please rate and review our podcast as well. We appreciate your feedback, and hey, be positive, share the love.